Okay. Hi, everybody. Welcome to EM Teaching for today, April the 22nd. I'm so glad to welcome you all to teaching today. Thank you very much for making the effort to attend. We're really excited. We're trying something new today, so bear with us as we make our way through this new process. I'm going to run you through the new format of teaching for today, and we'll run through a little bit of housekeeping and then move on to introducing our expert faculty for the day. So as you know from the meeting invite, this is our first ever cross-program webinar. We are collaborating this afternoon with EMPRET, and we are going to be tackling the theme of intubation of the COVID-infected patient in the EC today. The format of the session this afternoon will be a live video demonstration running alongside a slideshow presentation, followed by an expert panel session with time for questions from the audience. The session today is intended to be in one of two parts. We're going to be tackling intubation of the COVID-infected patients this week and addressing ventilatory issues of the intubated patient next week. Next week, we don't yet have any EMPRET faculty involved, but obviously, given that this is a two-part session, we would welcome faculty involvement, but equally, we're going to extend the invitation to the EMPRET team to join us again next week during our ventilation session. For the purposes of using this new Teams platform, thank you very much for getting on board and being so open to testing out a new platform. If you're joining us without video, either because your tech issues don't allow that or because you're at work, the recorded session will be made available to the participating group at the end of the teaching session. We also will be providing as much audio commentary along the way as possible. So even if you can't see the slides or can't see the video demonstration at the time, you should still be able to follow along with us because we're going to provide as much commentary as possible. I just want to get a couple of housekeeping issues out of the way. We're all new to the platform, and so to help us navigate smoothly through the session, if I can ask that you please mute your mic and turn off your cameras when joining and through the duration of the presentation. If there is a question that you'd like to ask, please feel free to post your question in the chat section of the group. The chat section will be continuously monitored throughout the session, and we will have a Q&A session at the end where we'll be able to collate those questions. If the question that you have is really pressing and you don't feel that it can wait until the Q&A session, please ask your question by turning on your camera, but keeping your mic off just so that you can draw our attention, and then we'll open up the floor for your question. There is the possibility that due to time constraints that we may not be able to address all the questions that get posted into the chat section. Our proposed solution to this is that we're going to be taking meeting notes of the Q&A session, and we'll distribute that at the end of the session. Any questions that we have not been able to address or tackle during the live session, We'll collate the remainder of the questions, we'll review them and populate them with answers, and those will go out in the meeting notes together with the recording of the session at the end. There will also be a feedback form provided through a link in the chat section. I urge you please to complete this feedback form, given that this is a new teaching kind of experiment for us at this stage. We're really piloting new ideas. And even though this is something that lends itself to our current physical distancing practices in COVID, I don't necessarily think that this needs to be kept to just this situation. And so ideally, we'd like to expand this idea in the future into our academic curriculum. So we really welcome your feedback and your critical evaluation of these sessions so that we can improve and adjust as necessary to the needs of the group. Okay, so let me move into introducing our expert panel and back-end support for the day. I am really excited to welcome the EMPRET team this afternoon. We have joining us today Prof. Andreas Engelbrecht. He's the head of emergency medicine at Steve Biko Academic Hospital and the University of Pretoria. He has a special interest in toxicology and emergency procedures, including emergency airway management. And so we are really thrilled to have him here with us on the session today. Dr. Vidya Lalu, also joining us from EMPRET, is a specialist emergency physician. She is the academic program coordinator and ultrasound coordinator for EMPRET, and she co-hosts together with Prof. Engelbrecht an EMPRET airway course, amongst others. In this COVID time, we're all having to find ways to cope. And so currently her nails are painted dark red to pretend to be Scarlet Witch, both for work, but more so for her daughter, whose birthday it was yesterday. So happy birthday to Vidya's daughter. From EMCT, I think everybody is familiar with Wasila. Dr. Wasila Khan is a specialist emergency physician practicing at Khayelitsha District Hospital and previously the head of unit of Easter River Hospital. She currently is the academic coordinator for the undergraduate emergency medicine curriculum and the MPhil program in emergency medicine at UCT. Wasila is similarly having to deal with the new lifestyle and challenges of COVID-19. She's now having to juggle academics, COVID planning, clinicals, students, and now homeschools twin boys, as well as raising a toddler and navigating around around all the hats that she's juggling. She feels that she's squarely in the clown corner, but we feel that she's very much the elegant acrobat. So no need for any jokes today. I think you're all familiar with me. I'm on your case a lot. I am Lauren Liking. I'm also one of the specialist emergency physicians on faculty at EMCT, and I'm the program coordinator for the MED program. Okay, so let's move on to the meat of the session today, which is why you're all here. I'm going to run you through the aims and objectives of our session today. We're going to cover a fair amount of content. I think it's quite an ambitious program. And so we are going to cover all aspects of the learning objectives, but we might not be exhaustive in being able to cover the full extent of these objectives. And so I urge you to continue with self-directed learning in being able to supplement what we have covered this afternoon. We'd like to identify the components necessary to optimize ideal intubating conditions. We want to demonstrate the cognitive aids required to assist with a structured, safe intubation. We are going to discuss the physical and psychological factors contributing towards a failed airway. We're going to outline the adaptations to the failed and difficult airway algorithm. And then as part of our Q&A session, we're going to compare and contrast the feasibility of novel intubating strategies, particularly as it relates to a protected intubation, discuss the unique challenges pertaining to team dynamics, and critically discuss the evolving evidence and areas of controversy. So if I can hand over to Vidya, if you can take us through the start of the session, please.
Thank you, Lauren, and thanks for having us as EMPRET on board. So before we get into the nitty-gritty about the indications for intubation, I think it's important that we need to, before we get into actually how to intubate, it's important that we talk a bit about the indications. So we know that traditionally, when you've got an ARDS type of situation, our indications for intubation have been things like clinical parameters such as a respiratory rate over 30, some blood gas parameters, perhaps a PF ratio less than 200, a PO2 less than 60, visually looking at your patient and noticing that they are tiring, they're using their accessory muscles, they're not coping with a prolonged tachypnea. So those have been traditionally used for ARDS, but however, when it gets to COVID-19, we know now that the pathophysiology of COVID is a little bit different to the traditional ARDS. And the lungs of the COVID patients are much more compliant than they are with ARDS. So this allows our patients actually to be able to cope with a higher respiratory rate for a much longer period of time without actually tiring. So that means that we need to adjust our parameters that we usually use for intubating to now compensate for this more compliant set of lungs with our COVID patients. So this now means that our COVID patients have sort of a trajectory that starts off as, the mildly symptomatic type of patient, and then they get to that group called the silent hypoxics. I'm sure most of you have read about it or heard about it, where the patient is profoundly hypoxic, maybe the saturation's in the 70s, but they're actually clinically very well. And these patients would actually not benefit from early intubation. So here is where we change our mindset from early intubation to actually later intubation, because if you've got a silently hypoxic patient whose sats are low, but they're actually quite comfortable, they're mentating well, they're not breathing too quickly, they can actually cope with that for a much longer period of time. And if we can support them with other measures, such as just face mask oxygen or high flow nasal cannula or NIV, we could actually delay or perhaps prevent intubating them altogether. We know that once we intubate somebody, the chances of them having mortality after being intubated ranges between 50 and 80%, depending on the literature that you look at, depending on the different countries. We've seen stats from 50% all the way up to 80%. So this really makes us reconsider that early mechanical ventilation strategy. So if you've got your patient with low saturations and you've got them on oxygen, you can maybe upscale from a non-rebreather mask, which is well-fitting, and include a nasal prong oxygen underneath that, which is running at 5 liters per minute, covered by a surgical mask to prevent the aerosols from getting into the atmosphere. If that is not adequate to get your saturations up, then putting your patient on NIV or high flow nasal cannula and using this new concept now of awake proning, that really helps us to stave off intubation as well. So with awake proning, it doesn't work quite as well with NIV, with the big mask on the patient's face, but with high flow nasal cannula as well as with face mask oxygen, it's quite a good option. You just ask the patient to prone themselves or to lie on their sides if they're a little bit obese, and you can actually visibly see the saturations coming up. So that being said, of course, there will be those patients that despite all of these maneuvers are going to reach that point in the progression of the disease where they have that cytokine storm and they do start developing a bit of that ARDS type of picture. And for these patients, it's going to be those that are actually having confusion. Their respiratory rate is now slowing down. So their CO2 is rising from a low CO2 to either normal or to a raised CO2. So once they develop this type 2 respiratory distress, respiratory failure type of symptoms, and if they are actually confused from their hypoxia, this is when we need to think about actually going straight to mechanical ventilation. So if I can summarize, I would say that the indications for intubation in the COVID-19 patient would be failure of your non-invasive strategies and your high-flow nasal cannula strategies, as well as clinical signs of confusion and type 2 respiratory failure. So as Lauren mentioned, we are going to be elaborating on the usual sequence of the RSI with a focus on the special tweaks that are needed for COVID-19. And Wasila is then going to kick you off with the special considerations that you need when preparing to intubate your patient.
Thanks, Vidya. Hello and welcome, everybody. It's great to be part of this collaboration. Thanks, Lauren, for the introduction and for elevating me to head of unit and MPhil coordinator. I dabble in much, mostly undergraduate program at UCT. Okay, so if we kick off, let's consider what we need to do in order to prepare. We are all well indoctrinated with the 7 Ps in preparing for RSI and intubation. However, we can all accept that the preparedness for protected intubation of a COVID-positive patient extends beyond just the airway trolley and patient. Preparedness takes on a bit of an expanded format in a pandemic and applies to any clinical procedure you engage with. Remember, there is no emergency in pandemic. We need to be mindful of always ensuring safety first and respect that there is no morning after full equivalent for the unplanned approach. Planning well will allay fear, your own and that of your team, and help mitigate risk of infection. So how best to prepare for protected intubation? This is my offering on expanding the 7 Ps for RSI that you are familiar with. Not only does it add in terms of additional considerations for preparation, but also expanded in time. This implies a thought process and planning that should already be in place. First and foremost, you need to prepare yourself. You are a precious and limited resource. Act the part. Ensure you get enough rest. Remember to eat well, as exhaustion and hunger magnify stress. Psychological well-being directly impacts performance, as we all know. So plan ahead with family and friends if you haven't already. Talk about the what-if scenarios. Having discussions such as what risk you pose as a frontline worker to family coming home from a shift, how best to mitigate that risk through shared decision-making. Having such conversations does well to replace fear and ensure both you and loved ones feel safe and supported. The second P here is also to prepare yourself as a practitioner. Reflect on what procedures you are comfortable to perform and identify attrition in skill. Now is the time to train or retrain. Work on your ability to communicate with colleagues and use the opportunity to expand and improve your team by ensuring that they also feel comfortable with the skills expected of them, be it donning or doffing or mixing drugs. Well ahead of our curve in this pandemic lies the opportunity to identify deficits and help train towards competence to ensure everyone's safety. Without the significant P, the wheels of safe intubation will simply fall off. The second is I have as preach and practice situational awareness. What is it and why have I isolated this particular skill in risk management? Allow me to explain. Situational awareness refers to being aware of what is happening around you, where you are in relation to other people or things, and what potential threats there might be. Good risk management involves consistently assessing situations for any existing or future threats or risks based on the current situation. So this situational awareness needs to be a shared one between hospital, unit, and intubating team. So why is this important? We all have innate cognitive biases based on previous experience or what we perceive to be true or likely. This arises when automatic thinking leads to a different conclusion from that which would have been reached with more analytical and deliberate thinking. It is this automatic, efficient process which makes it so useful, particularly from an evolutionary perspective, as it enables us to respond quickly to situations. In the practice of emergency medicine, it is particularly susceptible to cognitive bias because of its complexity, variety, and periodic hidden curveballs. Then you add in fatigue and time pressures and other distractions, all of which favor automatic thinking, and it is not surprising that biases commonly occur. This leads to stereotyping and to making inaccurate judgments, and leads to thinking such as priming. I'm sure you've heard it before. I've intubated 100 times before with this team. There's no need to go over the checklists for intubation. They will know exactly what to do. Or how about the premature closure? If it looks like a duck, sounds like a duck, and walks like a duck, it's a duck. There's no way the tube is in the wrong place. It's the ventilator. It's given us issues before. So these are examples of cognitive biases, which if we don't confront can lead to disastrous consequence to both practitioner and patient safety. But how do we go about harnessing the skill of situational awareness? Well, for one, you need to assess risks from all angles. Learn to look at things with a 360-degree focus, not just your own. Engage with your team. Be open to different viewpoints. Also look at what others might be seeing. How is that different from what you're seeing? Questioning without judgment is a key factor in situational awareness. Communicate with others. Being able to communicate the perception of risk is another vital part of overall awareness strategy. And any effective strategy requires everyone to be on board. And the best way to achieve this is to communicate each stage of a risk assessment or a potential hazard. This communication occurs at different intervals. So one opportunity is at the start of your shift. Have a team huddle, have a brief discussion on the COVID response planning, including the intubating the COVID positive patients. Use the opportunity to assign roles. It is also a good time to check in on teammates and ensure everyone is in a good psychological space to face the shift. Don't assume that just because you told someone about a risk or about correct procedure, that they actually heard you or that it was agreed. When communicating, it is much better to have a variety of ways to do this. So one such mechanism is the use of checklists, such as this taken from the Journal of Anesthesia on consensus guidelines for managing the airway in patients with COVID-19. This checklist delineates the processes which must occur outside the intubating room, inside the room, and that which occurs post-procedure. It also provides a second prompt to confirm verbal discussions you may have had earlier in the shift and can be amended here to include space on the document to write the names of individuals assigned to each role. What I like about these checklists offered by the New York General Hospital is an extension of the checklist specific for each person in the team and further elaborates procedures to be completed inside and outside the intubating room. So a topic of much discussion locally and in the global north is PPE and the shortage thereof. Nationally, we have specific guidelines on what and how PPE should be donned. Ideally, all items should be presented in a single sterile package. These arrangements can be made with CSSD depending on your institution. Otherwise, I'm sure we all have experiences where we've got to be running around the unit searching for different items to make up a PPE package. Alternatively, you could place a pictogram outside the room you're about to intubate in that can serve as a cognitive aid to ensure that all items are donned and done so in the correct order. This may be more feasible. Hospitals in the global north that have the resources have advocated the use of what they call a safety officer outside of the intubating room. This could be a fourth person and need not necessarily be a registered nurse or a doctor. You could take on board volunteers or even medical students. But what may be more feasible in our setting than using a person specifically assigned as the runner and safety officer is using cognitive aids or visual aids just outside the room. So if you are do have the luxury of having a fourth person. That individual is able to serve multiple functions. And if you do have access to that resource, then please, by all means, use it. Video, what is practiced in Pretoria? Do you feel the same dress in terms of, do you follow the same in terms of PPE? Is everybody in the intubating room wearing full PPE?
Yes, Wasila. So up north here, we have quite a similar practice. In the intubating room, we have 3 people, the intubator and 2 assistants. That may be another doctor and a nurse, or maybe 2 nurses, depending on availability. So all 3 of them are donned in full triple PPE. And then the assistant or runner outside is in a surgical mask, a plastic apron, and gloves. When we talk about triple PPE, we're referring to the layers that are covering the mouth and the face of the wearer. So this means that each person has got an N95, and then that is covered by either a surgical mask or a cloth mask. And then our third layer that we refer to is the face shield. And then there's also goggles underneath that. But you know, as you mentioned, the purpose of the surgical mask and the face shield, it's not really an aerosol stopping intervention, but it's more to catch the larger droplets and also to preserve our N95s. So I'm not sure about you guys, but we are reusing our N95s and trying to save them as much as possible. So by covering the N95 with a surgical mask, that allows us to prevent the N95s from being contaminated with things like vomit and secretions, so that we can reuse them for much longer. I like your idea of the safety officer outside. We also practice that, and I heard a cute little podcast that refers to them as a dofficer, a doffing officer. I thought that was pretty cute. And that is your person that is outside the room, specifically in charge of taking that cognitive load off the people that are intubating in the room to let them doff safely. So that person would basically guide them step by step into what they should take off, remind them to wash their hands with sanitizer, their gloves in between, and describe exactly how they doff their clothing layer by layer. So I must say, I love this combination that you've given of the visual aid to prompt the correct donning and then including the dofficer with that. That will be a great idea.
Yeah, indeed, I highly value these, especially in a high stress environment where there are multiple stimuli and distractions. It definitely does well to improve patient and staff safety as well. I completely agree with you. The doffer, it will be great to have, who stands by with a checklist and ensures that everybody removes the PPE safely. But yes, you know, the resources are a little bit scarce at times, especially after hours. So what our teams have done was perhaps take a junior doctor on board to act as the runner, and who at the same time acts as the buddy to ensure that donning and doffing is done correctly. So another visual aid I like is referred to as a dump kit. Essentially what it is a large laminated printout that you can place on the intubating trolley. Sterile packs of individual equipment is placed over its matched image. This makes it easier to avoid missing items, although it's useful to get CSSD to package intubation packs with everything in it already too, which we're trying to set up at Khayelitsha District Hospital. I have to say, to this particular dump kit, I would also add in inline suctioning and a McGill's forceps. If you are using a standard BVM, remember to include the HME filters in this pack as well. With regards to drugs, I would strongly suggest having an aid such as this. I've adapted for Khayelitsha District Hospital. This aid is laminated and placed on the wall outside the allocated room and on the inside of the intubating room, visible to the person responsible for drug administration. The drugs are mixed and labeled and placed in a kidney dish, which is then taken into the intubating room. Finally, once the best process in terms of preparations, you need to come together with your team and design what is the best process for you. And I suggest once that has been determined, the best you can do is practice, practice, and even more practice. Tell all the newbies about your policies and strategies during the onboarding process, and implement some situational training as part of the onboarding process too, or as part of ongoing training. By doing so, you can foster a very healthy culture of health and safety management. Now, this may seem like a lengthy procedure and feel somewhat unnatural when compared to how we usually approach critically ill patients who are in need of intubation. Yes, we do take precautions, but this adds on a far greater dimension that you need of little checklists that you need to consider. But it's important to remember that safety is paramount and that there is no emergency in pandemic. Vidya, do you agree?
Absolutely, Wasila. Our safety comes first. And once that is secure and we are safe, we can then shift gears to optimize our patients so that we can have a smooth and uncomplicated intubation with as little drama as possible. So we know that obese patients have a higher morbidity with regards to COVID. And this means that we will most likely be faced with quite a few difficult intubations. So we must remember that our usual methods that we use to optimize our first pass intubation success, they still hold. And this means anatomically aligning the patient so that the earlobe is in line with the sternal. In a non-obese patient, that means you can achieve it by placing the patient in a sniffing position. You may opt to keep the head of the bed elevated at 25 to 30 degrees, but ensure that the neck is still extended so that the face remains parallel to the ceiling. With obese patients, we need to apply graded padding under their shoulders and their head so that we maintain that earlobe to sternal notch alignment, as you can see in the picture. And you can do this by placing pillows or sheets or towels, whatever you've got available to you, as long as it's in that nice graded fashion to make sure that that earlobe is in line with the sternal notch. So remember also the usual good tips for intubation that go with it. And that is that the height of your bed should be at the level of the intubator's umbilicus or belt buckle, and that the patient should be close to the head of the bed so that you don't need to be leaning far forward to reach the patient. If a difficult airway is predicted, then of course you should have your anesthetic colleagues on standby, as well as all your usual rescue devices and difficult airway trolley and your front of neck access, whatever you may need for that, your blade, your bougie, your ET tube. Physiologically, we also need to optimize the patient so that we don't have a cardiac arrest situation on our hands. And that is our usual, resuscitate before you intubate mantra that we love to preach in emergency medicine. So we need to optimize the blood pressure, the oxygen status of the patient, and make sure that they're not, as little acidosis as possible. So with regards to blood pressure, we know that COVID can cause sort of a HAPE, like a high altitude pulmonary edema type of picture. And so giving fluids is a little bit tricky, and we should still be judicious with our fluid administration because we don't want to overload the lungs that are already having pulmonary edema. So once you've given a small judicious fluid bolus, you can actually move to preparing an adrenaline infusion before you even start with intubating the patient or before you've given any intubation drugs. You must have your adrenaline infusion running. If the blood pressure was adequate, you can have your push dose presser ready and on stand that it may drop.
I didn't catch that. Could you try again?
Sorry. If you're, just remember that you must get your patient to cycle, the nursing staff must cycle the blood pressure to be every minute during the intubation process, because it doesn't help if your blood pressure cuff is set to cycle every 10 minutes. By the time you pick up the blood pressure, you've missed the boat. So remember that if your blood pressure drops at any point during the intubation, that you will either up your adrenaline infusion or give your push dose of adrenaline ready and on standby. Now, the way that we use push dose pressors in COVID is a little bit different in the sense that we use it as we do when our blood pressure drops, but there might be another indication for using a little bolus of 20 micrograms of adrenaline as well, and that is the hypoxia. So you know that these patients are going to be profoundly hypoxic. We must actually expect that. We need to be mentally prepared to anticipate that the patients are going to desaturate. So don't let it flabbergast you. Don't start panicking. Expect it. And if it happens that the patient starts becoming bradycardic from the hypoxia, where normally we would have opted to bag the patient up, we are now going to use our push dose pressor to just sort of stave us over and prevent an actual cardiac arrest, because that's the last thing that we want in this scenario. Then with regards to acidosis, we know that the danger of acidosis is cardiac arrest. If you are intubating a COVID-19 patient that is in a septic shock-like picture, meaning they've got a metabolic acidosis already, and you then intubate them, cause them to be apneic for some time, they are then building up CO2 in the time when they normally would have been compensating with their fast respiratory rate. And so you then add on a respiratory acidosis on top of their metabolic acidosis. And this combination of metabolic and respiratory acidosis really just leads to too much acidosis, and that puts the patient at risk of having a cardiac arrest. So to try and avoid this situation, the most experienced person should be the one intubating, meaning that it's going to be done quickly. The apneic time must be as little as possible. So the quickest intubator must be the one at the patient's bed. And then we need to set the vent at the original respiratory rate that the patient was coping at. So those are two things that we can do to hopefully prevent a hypoxic arrest. Usually with a non-COVID patient, we would have added in there that you may bag the patient gently during the apneic time just to rid some of the CO2, very slow, gentle breaths, not increasing the lower esophageal sphincter pressure. But when it comes to COVID, we're completely avoiding using BVM. And so we are going to skip that step in this circumstance. And we're just going to try and avoid hypoxia by being as quick as possible as we can, and then ventilating them quickly to let them catch up after we've intubated them. And then that leads me to hypoxia. And we say that preventing, if the patient does become hypoxic, we would have given them that adrenaline push dose. But we also want to minimize our chances of that hypoxic arrest during the intubation, and that is to maximize our pre-oxygenation. So the goal here is to get us to saturations as close to 100% as possible. And the basic principle here is to remember, with COVID specifically, that whatever oxygen pre-oxygenation device you use, you must first put the device on and then turn the flow on. Don't turn the flow on before the device is already on the patient. It's especially important when removing that device. So if you've pre-oxygenated a patient and you're about to intubate them, you're going to remove that mask. First turn off the flow before you remove the device, so that you avoid pushing those aerosols into your atmosphere that you're about to breathe in. With pre-oxygenation, we've got a few options at our disposal. I'll tell you all options, and then I'll tell you which one we prefer to use here at EMPRET. So option number one is to hold a BVM over the patient with a tight seal onto the patient's face. Now, in this scenario, the patient is awake, they're sitting upright, and so pre-oxygenating them with holding a tight seal on their face, firstly, achieving a tight seal while the patient is sitting upright is not really that easy. And secondly, that patient is going to be quite claustrophobic if you're putting a tightly sealed BVM mask on them. So you may opt to facilitate this with ketamine, just like Scott Weingart describes in his DSI procedure. So you're having a procedural sedation for that pre-oxygenation with about 1 milligram per kilogram of ketamine. So that's option number one. Option number two, and this is the one that we prefer to do, and the reason I say that is because option number one ties up a provider who now has to be standing at the bed, holding this mask on the patient during the entire preparation process. So option number two frees up that provider. and that is to put on a non-rebreather mask on the patient, and that would be set at about 15 liters per minute, or whatever it takes to get the bag of the non-rebreather 2/3 full. Depending on the respiratory rate of the patient, it might be a lower or higher flow of oxygen. And with that, we put a nasal prongs underneath that non-rebreather mask. So that nasal prongs should be set at 5 liters per minute, not the usual 15 high flow that we usually speak about, and that is because of that risk of aerosolization. And then with those two on the patient's face, we then take a surgical mask and put it on top of the device. So we've got nasal prongs, we've got a non-rebreather, and then we've got a surgical mask on top to catch all the larger droplets that would be emitted from that contraption. So at Steve Biko, we are doing that option. And that is because it's just easier. It frees up our one provider. We don't need to procedurally sedate the patient for it. If that is not enough to achieve a high SATs, and that's ideally over 90%, but as I say, as close to 100% as you can get, and the patient was perhaps on NIV or high flow nasal cannula before you've decided to intubate them, then you should ideally leave them on the NIV or on the high flow nasal cannula and let them continue with that as their pre-oxygenation strategy. Option number 4 is sort of a makeshift NIV, which is also taken from Scott Weingard's DSI, where you've got your nasal prongs, you've got your BVM with your PEEP valve, but the settings here are different. And these numbers I've taken from George Kovacs, which is the Canadian airway guru, and he suggests putting your nasal cannula at 5 liters per minute, putting the BVM at 15 liters per minute, and setting your PEEP valve at 10 centimeters of water. So that contraption can give you a makeshift NIV as your pre-oxygenation to get the saturations as high as possible. Remember that you will have risk of aerosolization with these procedures, which will be donned in your full PPE and ideally in your negative pressure room. So we apply our pre-oxygenation for the usual 3 to 5 minutes, or as long as it takes to get all your equipment, your drugs, and your team prepared, and then you go through your checklists. So when it comes to drugs and doses, here we want to go with the option that are the safest for the patient in terms of not dropping the blood pressure, but we also want what is safest for us, and that would be, in the situation of COVID, the least chances of aerosolization. So we really want this patient to be paralyzed, that they do not cough in our faces. So if we talk about induction agents, it doesn't matter which induction agent you choose. All of them at high enough doses have got the potential to drop the blood pressure. And this would be the case if the patient's been septic for some time. Even ketamine can do it if they've exhausted all their endogenous catecholamines. So when it comes to dosing, you take that textbook that you've read your drug doses and you throw it away, because they've been designed for anesthetics with very wide awake patients who are anxious. And here we're going to use much lower doses for the induction agent. Ideally, we're going to go for ketamine because it's got the catecholamine surge that it gives us, maintaining our blood pressure and our heart rate. And it's got the additional benefit of having a bronchodilatory effect. But even if you use something like propofol, as long as you use half or even a quarter of the usual dose, you should be okay. Etomidate, as with all septic patients, it's controversial in the sense that there's the risk or potential risk of adrenal suppression. But we all know that studies have shown that a single dose shouldn't necessarily cause that much adrenal suppression. So if you've got nothing else, then that is also okay. With muscle relaxants, here we've really got our traditional choices, which is rocks and sucks. And that is what we are using here at Steve Biko. We are avoiding scoline because it's very short acting. If you think about the normal intubations using scoline, by the time you're securing the tube, the patient's already waking up and starting to cough and muster about, and we don't want that to happen here with these COVID patients, because we really don't want them to splutter in our faces. So we're going to go for rocuronium because of the longer acting nature of the drug. If that's not available to you, then you can use SUX and then add on any other muscle relaxant. So you can start with SUX and sort of immediately add on your VEC or your Tracheum or your Nimbex, whatever you've got available. When it comes to dosing of the muscle relaxant, remember, especially if it's a septic shock patient with a low blood pressure, that you want to go for the higher dose of the drug. So rocuronium, we're going to go for 1.5 milligrams per kilogram. That would be 2 ampules in a 70 kilogram patient, and give that quickly. Once we have administered the drugs, remember not to bag the patient as we normally do with all RSI. We don't bag. And at that point in time, you're going to position your patient to your preference. Remember also now to first turn off the oxygen before removing your pre-oxygenation devices. And then we're going to be ready to intubate the patient. So a few notes about intubation before we get into the video demonstration. When we talk about VL versus DL, that's video laryngoscopy versus direct laryngoscopy. Here we are advocating for video as the first choice. And the simple reason is that your face is removed from being directly in the patient's airway. And this then, of course, comes with the proviso that you have practiced and are confident in your abilities with the video laryngoscope. When it comes to placement of the video, you need to make sure that it is next to the patient in your line of vision. So you cannot have your video laryngoscope at 90 degrees to you, and then you have to turn your face 90 degrees every time you need to look at the screen. You need it to be as natural as possible. So placement of that video is quite a critical point. And then depending on your video laryngoscope that you've got available, the introducer can be an important make it or break it factor. If you've got an INTUBATION, for example, that comes with a flexible introducer. And Prof will demonstrate just now how to bend that, that introducer so that it's in the ideal position to pass easily through, and it's different to that of a direct laryngoscopy. If you're lucky enough to have a rigid introducer that comes with your machine, like a GlideScope does, then that is perfect. You just use the introducer as it is. Please don't try to bend those introducers, they will break. The other thing that can help you succeed in first pass success intubation is this 50-50 view. And what I mean by this is that once you get the view of the cords, you've got a beautiful view, you can see everything. It often happens that when you try to pass the tube, you just cannot get the tube in. So if at that point you relax your hand, make your view suboptimal, so you can only see the tip of the arytenoids and maybe the bottom bit of the cords, just sort of 50% of your view, and you can see your epiglottis blocking the rest, top half of your view. Somehow that relaxation of your hand allows the angle to be less acute and the tube passes a little bit more easily. So that's just a little troubleshooting while you're intubating if you're unable to get the tube in that you can try. Also remember external laryngeal manipulation. That's something that we always use even for direct laryngoscopy. And that just allows you to see the cords better and pass the tube through. Your assistant will be able to see on the screen exactly what you're seeing, so they'll be able to help you with that. So the Intu box, I see it's on the slide, but we're going to leave that for the panel discussion later. So with that, I'm going to leave you in the capable hands of Prof. Engelbrecht to demonstrate the technique. Just note that Prof will not be wearing the full PPE to allow for the sound quality to be optimized. And he's also not going to have any monitors on the patient because that's also going to distort the sound. So I'll leave you with Prof now.
Okay, Almin, are you ready?
I am ready now.
Excellent. Okay. I've got this patient on a non-rebreather face mask and nasal prongs, and I've got a surgical mask on. Can you open the oxygen for us? Can you please open the...
Prof, if you can just make sure that your mic is on, please.
Okay. Can you please make that the mic on?
Yes. Sure.
Vidya, can I confirm that you hear me? Can you hear me?
Yes, Prof, we can hear you fine.
Okay, fantastic. Okay, so Almin, can you please open the non-rebreather for me to 15 liters per minute?
Okay, the oxygen is on at 15 liters per minute.
Can you open the nasal prongs to me for 5 liters per minute, please?
Nasal prongs on 5 liters.
Excellent, excellent. Okay, can you please draw up drugs for me? I want ketamine 1 milligram per kilogram, so that's going to be 70 milligrams. Thank you. And I want rocuronium 1.5 milligrams per kilogram, so that is going to be 2 ampules. Thank you very much.
Okay, the drugs are drawn up, ketamine and rocuronium.
Let's check our video laryngoscope. They said they can hear me. Just confirming that you guys are hearing me.
We can hear you fine. Thanks, Prof.
Thank you. Almi, are you ready to administer the medications? I see our patient was very hypoxic and we need to intubate her. Can you go ahead and give the induction agent for me, please?
Okay, Prof, I'm doing ketamine, 80 milligrams. The ketamine is in.
Thank you.
Okay, now I'll be giving rocuronium, 2 amps. Rocuronium is in.
Okay, while we're waiting that the patient is going to become paralyzed, she's still breathing spontaneously, I'm going to bend my introducer in this shape, which is the ideal shape. How's my sats?
We've got stats of 98%.
Well, that's very lucky. Thank you. And I think she stopped breathing. I'm going to put her down now. Almin, I want you to close the oxygen at the wall, please.
Okay, the nasal prongs is off, the non-rebreather is off. Oxygen
Thank you very much. So that is a Cormac Leane 1, but I'm going to let go and have a 50-50 view. Lamin, can you blow up the cuff for me, please?
The cuff is blown up.
I can see that the tube is still through the vocal cords. Lamin, when I tell you, can you please clamp the ET tube for me? Please clamp it.
The tube is clamped.
Thank you, Almin. Can you please connect the viral filter for me?
Viral filter is connected.
Can you please connect the ventilator?
The vent is connected.
Thank you. We can let release. Thank you, Almin. Let's look at the ventilator and look at our settings. Let's just confirm tube placement. Can I have a look at end-tidal CO2? I see a good end-tidal CO2 measurement, and I'm visually seeing that the chest is rising. Thank you very much, team.
Okay, thank you, Kamran. We can go back. Great. So as you guys saw, Prof and his assistant were in full triple PPE. They prepared all of the equipment and the team beforehand. For the pre-oxygenation, they used a non-rebreather mask and a nasal prongs at 5 liters per minute with the surgical mask on top. He opened the oxygen only once the mask was on. Drugs were administered as usual. Prof used video laryngoscopy for the purposes of this demonstration. The video was turned so that the audience would get a better view, but in real case, it would obviously be in line with his vision. Once the tube was in, he asked the assistant to first inflate the cuff. Then he confirmed the position with his video while still the video laryngoscope still inside the mouth. Once confirmed, he then removed the video laryngoscope. The assistant then removed the introducer and clamped the ET tube. First connected the filter, and the end-tidal CO2 attaches onto it, and then the preset ventilator was attached, not the BVM device. So you've got a closed system at all times. The tube was then unclamped. We can move to the next slide. The confirmation was then done by visualizing chest rise and by using the end-tidal CO2, not by leaning over and listening to the chest and thus contaminating your stethoscope, or by leaning over, you also put yourself again in that patient's airway. An NG tube is actually preferred here in COVID over an orogastric tube, because as you all know, with an orogastric tube, it is inevitable that you end up back with your laryngoscope in the patient's mouth, fiddling around in there and with curled up NG tubes. So nasogastric is preferred over orogastric, just because of ease of passing it through. And then because the patient is paralyzed for a longer time than usual with the scoline, that we're used to with scoline, you need to have your sedation infusion ready, like a domicum infusion that should be ready to go. So all of the above is good and well if everything goes well and the tube passes without any incident. But what happens if we're faced with a difficult intubation? Well, we must have it separated very clearly in our minds, the difference between a predicted difficult airway and a failed airway. In the predicted difficult airway, you have lots of time. You anticipated it, so then you called for help early. You got your airway trolley there. You've got experts. Maybe you've got an anesthetist with a fiber optic scope at your side. So there, things would be much different. When you're in the situation where you've come up with an unexpected failed intubation, then your options are limited. Our usual pathway for an unexpected failed airway is to immediately bag the patient up. And if the saturations come up, then we may try twice more with things done differently each time. Maybe you change the blade, maybe you say change the size of the tube, change the position, you do something differently, use a bougie perhaps. And if that fails twice more, then we usually move to a supraglottic device. And if at any time we could not get the sats up, we go for front of the neck access. So what Wasila is going to do is she's going to take us through the tweaks to the usual algorithm and tell us how it differs when it comes to the COVID era.
Thanks, Vidya, and thanks, Prof, for a great demonstration. So what do you do in the event of a difficult airway? To begin with, if you communicated your plan A, B, and C at the very beginning with your team, this part becomes far easier. So there are two scenarios here. One, where you can't intubate, and two, you can't ventilate. Camlin, you can change the slide. So what do you do? I would suggest still clamping the ET tube as you withdraw from the patient's mouth. Have your assistant stand by with the refuse bag waiting to receive it. And then immediately have your assistant place the BVM over the patient's face, PEEP valve attached to create a closed circuit. And ensure a tight seal. Just like Vidya said, we want to be able to reoxygenate this patient without having to bag. Okay. Thereafter, consider why the intubation was unsuccessful. Perhaps consider repositioning. And if you haven't intubated the first time using video laryngoscopy, and you are the most experienced person available to do so, and you have it available, of course, then use the instrument available at your facility. Most often, we've got the glide scope in the Western Cape with the CMAX as an example. If VL is not available, then proceed to a supraglottic airway. Remember once again that the patient must be adequately oxygenated between attempts. If this is successful and you can ventilate adequately, indicated by chest rise and end-tidal CO2, then communicate so with your team and proceed with post-intubation care. But then what happens if you're unable to ventilate with the supraglottic airway? Well, then communicate once again, very important, with the team and your assistant to prepare for front of neck airway and then proceed. Now, there are some facilities in the Western Cape who have actually moved away from choosing to do a front of neck airway. There could be various reasons for that, one of which is a lack of skilled staff, especially after hours. However, there's also a misconception that front of neck airways pose an increased risk to the practitioner, and it is increased risk or considered an aerosolizing procedure. But according to a systematic review, the front of neck airway poses a lower risk of aerosolization than tracheal intubation. Therefore, doesn't place the practitioner at increased risk of infection. But it's very important that if performed, it must be done so by the most experienced with the aim of achieving a definitive airway in the shortest space of time. So that very quickly summarizes how we would approach the difficult airway. Having said this, the anesthetic guidelines advocate for 3 attempts at a direct laryngoscopy. I would have to say that if you approach the airway and you feel that this is not actually going to work with the direct laryngoscopy, then please proceed, move on to video laryngoscopy, move on to supraglottic airway. So what we're trying to do is limit the amount of time you were spending at the airway attempting to achieve a definitive airway in this patient. Okay. So that, I think, summarizes intubation, and I will hand over to Lauren to take on any questions.
Great, thanks, Wasila. Thanks very much, everybody. I think that was a really great rundown of how to approach the steps of intubating a patient. I think in terms of how this is similar to our everyday practice, we know that the intubation goal remains the same. We have the same objective as any other intubation, that we want to ensure a high first pass success rate, and we want to work with a team that we're familiar with. We know that in this kind of clinical situation that we need to include the additional considerations of having complete equipment. We need to know how to manage oxygen flow safely, and we need to be liberal in our use of checklists to help with our cognitive checkpoints. And I think all of those points have been really well covered and summarized during the course of the session. So thank you very much for that presentation. I think just before we move on to the Q&A session, I just wanted to make the observation that, we are trying to present the information as we know it today. So I said this to the registrars many times before, that things evolve on a minute-by-minute basis. And so we have to be open-minded in the way that we take this forward. I think being able to prepare and discuss and consider the issues in advance of requiring to perform the procedure is really important. But equally important is that we need to remain cognizant that things are going to change. As much as we try and plan and as much as we try and prepare, there is going to be a point at which we're going to have to be agile, we're going to have to adapt, and we're going to have to be open to considering changes to our approach. And so I would just add that as an addendum, that we are providing the best possible approach at this given time with the information that we know. And that really is part of the discussions and what underpins all of our COVID-19 discussions, is that, and airway management is no different, is that we're forced by circumstance, really, to commit to processes and procedures using evidence that is anecdotal, that is based on expert opinion, that is based on consensus. And so that makes us feel a little bit uneasy. And we accept that and we acknowledge that, but it's not really anything that we can change right now. And so let's just be considerate, let's be calm, let's have rational discussions, and we move forward in our discussions. So I think that is a good jumping off point for Q&As. Camlin and Luke are going to be on the side collating those questions for us. And so just as they're beginning to pull through all of those questions, I'm going to kick off the session with Prof, with Wasila, and with Vidya. I think that we have all been reading with much interest around the concept of barrier devices in a way to assist us with a protected intubation. What are your feelings around the kinds of barrier devices that are available to us, and whether you feel that this helps or hinders our intubating safety and efficiency?
Yeah, thanks, Lauren. I think I can respond in a bit there. You know, we understand that tracheal intubation is potentially high-risk procedure for the airway manager, particularly as it risks exposure to a high viral load. And if transmission occurs to healthcare workers, this may be associated with more severe illness. But at the same time, we need to consider what's most practical in our setting and what's going to allow us to achieve a definitive airway in the quickest time. Now, I've had some experience. We were playing around at Khayelitsha District Hospital trying to simulate what it's like with intubating using the plastic box. And I'm going to use the term plastic box because I understand that our colleagues at VITS have designed something that's quite different, and apparently it might just be a lot more user-friendly. But we did attempt intubation with an INTUBOX, and that with a plastic box, and that was really difficult to visualize the vocal cords, and it was quite limiting in terms of movement. And it was a larger gentleman, and we really couldn't get that the box to be well placed over him. So really, how much of benefit that was in relation to having a failed airway, really to us, we couldn't see the value in using that particular box. We then proceeded to use a plastic sheet, you know, the ones you're all familiar with, that we collect patients, or the nursing staff collect patients' clothing and place it in there. Well, we opened that up into a sheet that covered about half the patient, with 2 slits in for the intubator's arms. We found that that was a little bit better. We certainly were able to intubate the patient a lot easier, but at the same time, it was a little bit fiddly. And just the other day, our good friend Saad Lari sent through a video that Kamil Volib's using the UAE, and his team has used a similar plastic sheet, but one that covers the patient from head to toe. And it uses the tenting sort of technique where you've got your IV poles up at the head of the bed, and the sheet is clipped onto those IV poles, and the sheet is tucked in under the mattress. And the idea there is there are 2 slits in which the patient or the airway manager accesses the patient's head, and the assistant has a slit in front that allows them to access the front to pass equipment. And the idea is that the patient is always in this plastic tent, and even if they move from EC to ward, that tent remains on. So it seems a lot more friendlier to use as a barrier device. I assume the patient is going to end up being quite moist after a couple of hours, but I can understand, you know, that there would be an advantage. But then we really need to consider then a lot of the experience that comes from using the plastic boxes for intubation comes from mostly the global north, and people are intubating in rooms with negative pressure, and you are intubating in a very closed environment with all of your resources at hand, and that everybody, by the looks of it, is using video laryngoscopy. And we really got to weigh that up against the fact that we don't all have video laryngoscopy, firstly. We don't all intubate in rooms with negative pressure extraction, and we don't all have the necessary skills to be able to advance and to, you know, secure an airway in short time, especially after hours. And so I I'm really, really sitting on the fence here. And I have to say that it really depends on what resources you have available and the person that's actually managing the airway. I don't know, Video, have you had any different experiences with it? Have you used the Intubox that our colleagues have designed?
I must say, Wasila, I tend to agree. It is a difficult call. So with regards to the box, we'll talk about the plastic in a minute. There's some pros and there's some cons. So if you think about the pros to using the box, it is good as a barrier for actual droplet transmission. There have been some experimental studies that say that the amount of droplets on the intubator's clothing after using a box is significantly less than without the box. That being said, we are doing an aerosolizing procedure. So the droplets that are large are not our biggest concern. It's actually the smaller aerosols. And so for that, I mean, there's so many technicalities around the box that are unknown. You know, you're going to have a concentrated aerosol in a space that has decreased airflow if you've got the box on. And then at which point have you put the box on in the first place? Because you've given your patients drugs, you've now lowered them down. It's going to be an extra step when the patient's already desaturating, so you have to put the box on at some point. And then at what point do you take it off and then expose all the concentrated aerosols now to the environment? So, you know, the pros are you know, the bigger droplets that get contained, but the cons, together with this aerosol that's then potentially concentrating or maybe not at all contained in the box, it adds on to what you said about the actual procedure with the box on. So now you've got this box, but then accessing the airway is a little bit more difficult. So I would say if you do use it, it must be in a predicted easy intubation. It definitely cannot be in a predicted difficult intubation or an obese patient where you can't get the box over the shoulders, because then your access is much further forward. Your laryngoscope is bumping into the top of the box. So there's all sorts of technical issues that become problematic. With regards to the plastic sheet, I've seen our colleagues in anesthesia, and they say they've been using the plastic sheet, but not so much for the intubation as for the extubation. So they are actually not using it for intubation. We've tried it out in sort of a mock scenario, and it's really, it's just all over the place. It keeps falling off the bed. It's not really easy to use for intubating. They say that they are using it for extubating the patient when you're expecting a patient to cough and then they want to maintain those larger droplets in the plastic, and then they carefully, you know, remove it from the top and dispose of it carefully to keep all those droplets in there. It would be interesting to see that video that you say Kamal and them use. Maybe you can send us a link to that video and we can see how that would work. It's hard to kind of imagine a patient fully covered with slits just for the airway. So I don't know, a very stifling mortuary-like picture that you're painting.
Nicely
that
contained.
video would be interesting to see. Yeah, Prof, I don't know if you want to add anything.
No, I think I really agree with all your sentiments. I am concerned. I think we must just remember what scenario we are facing here. We're facing not so much a difficult airway as we face a physiologically difficult patient who is tachypneic and hypoxic. And my experience is that they desaturate very quickly. And I think, you know, we don't just intubate patients that we know are COVID positive. It's often also the person under investigation. So it's a physiologically difficult patient that desaturate very quickly. And I think adding the box does add an element of difficulty. And I'm not sure if it's the right thing to do. So I'm receiving a lot of these boxes now, and I'm sort of very hesitant to distribute them because I'm just not knowing if people know what they let themselves into when they're going to try to use those boxes. I think you need to practice, and like Vidya said, I think it must be a predicted easy intubation. It mustn't be a one where you know you're going to struggle, and you should really stay away from that thing. It's gonna make it harder for you.
Your mic, Lauren.
Okay, thank you very much. I think that's all very helpful. I think it definitely unpacks some of the concerns that we've had about these barrier devices. And I think it, if anything, re-emphasizes the fact that if a barrier device is going to be employed, that it is absolutely crucial that it isn't employed for the first time during the intubation of a COVID-infected patient, that then we really do have to be committed to creating simulations and practicing with these barrier devices ahead of time so that we're not caught unaware, because it's an added cognitive consideration for us when we approach this kind of thing. In addition to the fact that, you know, I think we really need to then emphasize the basics. And so you touched on it, Vidya, that we just need to make sure that the patients are deeply paralyzed. And so in the condition and in the situation where the patient is deeply paralyzed, you know, again, we don't really know what is the risk then of generating aerosol particles. But presumably in a patient that is deeply paralyzed, the patient is then not going to cough, is not going to splutter, is not going to be generating aerosols from themselves actively. And to what degree will our interventions create aerosolization? It's unclear, but you know, we stick to the basics of ensuring that there's deep paralysis, and that in and of itself will decrease the risk of aerosolization and risk to the provider. Okay, all right. So if I could then just very briefly get your opinions and your thoughts with regards to strategies that we can perform and considerations, additional considerations regarding our pre-oxygenation, apneic oxygenation, and re-oxygenation strategies. I know that the emphasis is always to reduce the amount of aerosolization, that we want to keep our oxygen flow rates low, and that we genuinely will work in an environment where the airflow is quite poor. And so do you think that at any point there's room to consider high flow nasal oxygen, nasal cannula oxygen, or CPAP, non-invasive strategies such as CPAP?
Maybe I can take that one, Lauren. So when it comes to using high flow nasal cannula and non-invasive ventilation, yes, we know that the risk is the aerosolization. So, but we also know that we have to balance that against the other option, which would be early intubation, and that's sort of, you know, dooming the patient to a higher mortality rate. So what I recommend is that if we do use high flow nasal cannula and we do use non-invasive ventilation, that we make sure that we, as far as possible, put those patients in a negative pressure room. Here at Steve Biko, we've got just one room, our isolation room, that is negative pressure. And right next door to us, we've got the TB ward that we're currently using, which has about, I'm not sure how many beds it has, about 10 beds, and that is a negative pressure room. So if we have those available, then we should be using those rooms when we are using these aerosol producing procedures. The second big thing is that everybody in that room must be in full PPE, full triple PPE, so that they minimize the risk to themselves. They say that high flow nasal cannula is about as aerosol producing as a normal nasal cannula. So we sort of taking that risk when we put the nasal cannula on, and we're minimizing that risk by putting it at 5 liters per minute instead of higher flows. I think we just have to be careful. If we don't have negative pressure rooms, perhaps we put them in the tent outside or the field hospital or a well-ventilated room, and sort of all of the NIV patients in one room, not mixing with any other patients. Make sure that there isn't a non-COVID patient right next door that's going to be breathing in all the aerosols. So that's my take on those procedures.
Okay. Lucila, do you have anything else to add?
No, I think Vidya covered it all. It's not an absolute no-no. It's discouraged under certain conditions, and if we are going to use it, then we just really need to make sure that we have an appropriate area to place these patients. And I know that some of us are limited in terms of where that space is and what resources we can assign to those areas. But like I said, it's all in the preparation and in the communication that needs to happen early on. And being aerosolizing, then, you really need to weigh up the pros and cons and really the risk for your specific unit in that time. But yeah, I think Vidya's covered all of the important aspects already. Thanks.
Great. Okay. If I could just then jump to a couple of the questions that the registrars have been posting just in our last couple minutes of the session. A question comes from Dr. Dopé. She asks, in a situation where you're unable to successfully intubate a patient and there's a significant desaturation during the apneic period and an attempt to place the ET tube, would you still absolutely avoid using BVM and go directly to supraglottic or front of neck access?
I don't mind taking that one. I don't know, Wasila, if you want to take it. So what we are advocating is we're going to give that push dose of adrenaline if they're becoming bradycardic from the hypoxia, but we're going to allow a certain degree of hypoxia that we wouldn't normally. If you do get to that point, and you really might, where they're so hypoxic and bradycardic and your adrenaline's maybe not pushing them through and you really do need to bag them up, then we are completely not using first generation supraglottic devices. We're not bagging them, but second generation supraglottic devices are then advocated. So that would be anything that's not an LMA classic. So your iGels are second generation, your LMA Supremes, your ProSeals, any of the other varieties, or intubating LMA, any of those are considered second generation supraglottic devices. And so if you do feel that you have to sort of bag them up, then pop in a supraglottic device and use that to rather bag them up. And then if that fails, of course, you're going to have no choice but to go for front of neck access.
Okay, great. Thank you. I think that does answer the question really well. A question that I think speaks to something that we need to definitely consider in our selection criteria for our intubating patient comes from Dr. Dunn. She asked, is it practical or necessary to intubate all patients from now on in the EC as assumed COVID positive, especially in the situation where we have no time to screen? So I think the question really is, in the situation where we are having to intubate a patient, do we just presume that all patients are COVID positive until proven otherwise?
Yeah, I can perhaps add to that. Certainly, I think all ECs nationally, if not worldwide, are currently restructuring to ensure that we separate areas into respiratory and non-respiratory. And most would already have assigned a separate respiratory resuscitation room and separated from patients without respiratory symptoms. Now, granted, we do and we are finding patients who are asymptomatic and presenting differently who, in hindsight, were positive. But I'm speaking simply from the point of if a patient does present with respiratory symptoms and you are unsure whether they are COVID positive or not, I would assume they are positive and make certain that they're intubated in the respiratory recess. Vidya, do you practice any differently?
Yeah, Prof, we basically do the same thing. I think Prof wants to elaborate.
I think I just want to say something about patient flow. And that is we all having, the field hospitals where we tend to cohort these patients together. And, our experience of intubating these patients a lot of it has been for patients that are still under investigation. So we get our pneumonias and we get our asthmas and our COPDs. And because they technically meet case definition, they are persons under investigation. So then they, for normal reasons, require intubation. So I think the steps that we've demonstrated then applies to these patients. The PPE that we demonstrated then applies to these patients. But what I just want to add in terms of patient flow is one have to do a little bit of risk assessment of these patients, because I feel it's very important not to put patients that are highly likely to have COVID close to patients that have better explanations why they meet case definition than COVID. I don't think it's a good thing to put your COPD patient and your patient with unexplained pneumonia who's been in contact with somebody with COVID next to each other, because we are really going to cause that patient with already comorbid lung disease to become infected. So I think it's very important to do that sort of separation of these patients into ones that are highly likely to have COVID. For example, patients with unexplained pneumonia, so patients with contact with COVID positive patients, and then other patients that just simply have heart failure and kidney failure and COPD and asthma, but technically meets case definition. But for all of them, we should really be applying the principles that we've just discussed in the next couple of months.
Yeah, excellent. I think that covers all the points really, and it highlights the need for having experienced providers on the front line to be able to kind of discriminate and make this kind of differentiation, because I think, you know, a junior registrar would be hard pressed to commit to that kind of distinction. But one, it requires that we carefully think out the kinds of guidelines that we're using, the kinds of severity scoring and early warning tools that we're applying, and then the need and the value for experienced and clinically astute frontline providers. Okay, I think we're almost out of time. I'm going to push us, I think, just 5 minutes over, just because I think we're having a really good time. So, or I am. So, just one more question. If we have no end-tidal CO2 monitoring, what would be the recommended way to monitor tube placement? And then as an offshoot from that, is it possible to have a protected point-of-care ultrasound device in the room and then potentially use point-of-care ultrasound to confirm tracheal intubation in so far as you can identify right versus left?
Okay, I think I'll take that one. So to the first question about confirming if you don't have end-tidal CO2, your options are then limited really to watching the chest rise. So you must look for chest rise, look that it's equal as well. If you do want to use your stethoscope, avoid leaning over the patient, rather go from the side that you're not going over the airway. And then really you have to decontaminate your stethoscope as well after that. So that's why we're rather advocating for just looking for chest rise and hopefully end-tidal CO2. With regards to ultrasound, so ultrasound is actually useful in a lot of ways in COVID, but you do have to have a dedicated machine then for your COVID patient. So you need a COVID machine and a non-COVID machine. That's really the only way, because if you're going to attempt to decontaminate that machine every time, like completely, think about the trackball, think about the little intricate parts that you would need to, I mean, we will do a superficial cleaning each time, but you really should have a dedicated machine for your COVID patients. And if you do have one, then yes, you can definitely use it. It's very helpful to assess the fluid status of the patient, as we usually do, because like we said, we need to be judicious with fluids for the COVID patient because of the pulmonary edema. So it would be very nice to look then at the IVC, look at the contractility of the heart, look at the amount of basal sort of B lines, although that might be a bit misleading with the COVID lung as well. But looking at the IVC would be really helpful. You can definitely use the ultrasound to confirm placement, but you have to know how to do that. So you shouldn't be trying it for the first time on your COVID patient. Practice it on your non-COVIDs beforehand, before you then start using it to confirm placement in your COVID patients. And then, I mean, ultrasound can be used as well for sort of grading your COVID patient in itself. So some people are, an Italian guy called Giovanni Volpicelli, he is using it for triage of patients. So it's sort of the decision aid as to whether these patients should be sent home to self-isolate or whether they should come in if they've got, B-lines on their lung ultrasound at triage. And then it can also be used as a critical decision point when deciding whether to admit your patient to a ward or to an ICU. So then again, using your lung ultrasound is going to help to distinguish the severity of your disease process in the lungs to help to distinguish it in that way. So ultrasound is actually a whole talk on its own. Maybe we'll put that on for a future date, but it definitely has a place in COVID.
Excellent. Okay, last question. This is a question from Dr. Fatela. She asks, in a distressed patient, can you consider placing a patient prone with a non-rebreather before making the decision to intubate or while you prepare for intubation?
Okay, I'll take it again. Unless you want to, Wasila. Okay. So yes, the answer is yes, you should. I think I have mentioned it in the talk. You should definitely awake prone, and that might even stave off intubation. If you're going to use it for pre-oxygenation, just make sure that you reposition your patient supine when you get to the point of I'm about to give the drug, so that you don't then start fumbling about with the paralyzed patient and now they're becoming hypoxic. So definitely in pre-oxygenation, you can prone your patient, and like I say, it can in fact stave off the intubation at all.
Yeah, I agree with that video, and we've had some good response to that maneuver as well, which some are describing as a rotisserie method. So you have a patient on the non-rebreather, you have a nasal cannula as well, if that helps, under 5 liters, of course, and you have them spend an hour or two supine, then turn them to the right, then they're prone for another 2 hours, and to the opposite side for another 2 hours. So basically, it's very much a rotisserie. And even if a patient presents with SATs of about 84% or so, or a little bit lower, we allow for that. And we find that just using that maneuver and allowing them prone or time with oxygenating prone actually helps quite a bit. So there's definitely maneuvers you can consider before going in to intubate. Remember that once you intubate a patient, that mortality risk is quite high. So you really need to think long and hard about it. But you also need to think about what sort of backup support you have and on the patient in front of you and their physiology and what they're able to contend with. And obviously, if they're compliant enough to allow you to perform those maneuvers.
Yeah, absolutely. I think that covers it a lot. And I think, much like all of the other decisions that we make in the emergency center, it happens in a spectrum and a package of care. So we know that if the kind of patient that is requiring a non-rebreather together with prone positioning, that kind of patient is not leaving the EC to go home. And so even if it just creates a little bit of a cushion to be able to start the discussions with the definitive care pathway and the accepting specialty, whether that be high care, whether it be ICU, whether it be whatever the eventual disposition of the patient will be for definitive management and ongoing management. I think that there's definitely value to that. And anything that buys you time to help you to prepare better, provided that it doesn't delay your management, I think, or put the patient at increased risk for clinical deterioration or rapid deterioration, where you then have to deal with a precipitous kind of clinical decline, I think is of value for sure. Okay, if I could just then open up the floor to Wasila, to Prof, and to Vidya as to whether or not you have any closing statements, any general observations, anything that you'd like to leave with us as any specific pearls or pitfalls that we haven't covered before we start wrapping up. Maybe we start with you, Wasila.
I'm good, thank you. Just to drive home the need to prepare adequately, to communicate, and please just upskill. Ensure that you are skilled. The glide scope attempt done last year, well, you need to actually go back and try and simulate that with your team and ensure that you can still do it. And yeah, just remember, please take care of yourselves. It's uncertain times, and everybody's working really hard. Thank you for that. But yeah, I think that's about it. Thank you.
From my side, I think just remember, I must say this was a very valuable session, and thank you for the great idea and hosting it. And I think everybody's learned a lot from these, a lot of take-home points within the talk that we've had itself. If I can just say one thing, and that is just remember to be calm. Sort of take a breath. Maybe it's in that time when you've given the drugs and you're waiting for the patient to be paralyzed. Use that moment to take a deep breath. This is my yoga side coming out now. Do a little bit of, tactical breathing. Calm yourself down, lower your heart rate. Accept hypoxia. It's going to happen. Let it be. Just don't panic. Be calm and you'll be fine.
Yeah, I think from my side, I really want to sort of add to what Vidya and Wazila said already about just preparing yourself mentally a little bit. I think, we showed you some tips about how you can do it, but don't be, flustered if you forget one of the little steps. It's not that important. I think the important thing is have your patient properly paralyzed, and you shouldn't have a big aerosol. Another thing I just want to say is, when you don all these PPE, you can feel very like it's almost like you become as hypoxic as the patient becomes. So just take a moment, like Vidya said, just allow yourself a moment to calm down from that very suffocating feeling of all that PPE on you, and just sort of take a couple of deep breaths, calm yourself a little bit. No intubation is ever absolutely perfect, but these are just showing you the tips and the potential things that you can do to make it safer for yourself and ultimately safer for your patient as well.
Okay, great. Thank you very much. I think wise words from a well-deservedly labeled expert panel. Thank you very much for joining us this afternoon. We really appreciate your time. We really appreciate all the effort that's gone into preparing for the session. There are a lot of unseen, behind-the-scenes faces, so I'd like to also extend thanks and acknowledgement to Camlin, to Luke, to Pumla, and to Elmin for all the behind-the-scenes preparation and planning. There were many dry runs upon dry runs upon dry runs. And I think, we're really proud of the session. So I really hope that this has been useful. We hope to see you all again next week for our ventilation session. Dave Fredericks will be presenting. He is one of our specialist emergency physicians. He's our ventilation expert and probably as close as we have in South Africa to Scott Weingard. And he also is an intensivist working at Groote Schuur ICU. So I know he is, I don't know if he is anymore, but he was listening a little bit earlier. And so we are excited to see him next week, and I hope you all join us again. If I can just re-emphasize, please fill out our feedback form. I would really appreciate it. Please don't hold back. The feedback is very helpful to us in being able to plan ahead. Don't be mean, but please be critical. Be gentle, gentle but critical. And then we will be distributing out the video link to this session, as well as the meeting notes with the Q&A. We didn't get to all the questions, unfortunately, because we've run out of time. So we will add those questions that weren't addressed during the session into those meeting notes, as we mentioned at the beginning of the session. Thank you very much, everybody. Have a lovely afternoon. Please be safe and look after yourself. And we'll see you next week.